Our next speaker, Dr. Mia BIondi. She is assistant professor at York University. Mia BIondi received her PhD in microbiology and immunology from McGill University with postdoctoral fellowship at Toronto General Research Institute and the National Microbiology Laboratory. During her postdoctoral fellowship, Mia completed her clinical training at Western University to become a registered nurse and then nurse practitioner. Clinically, she is a practicing primary healthcare nurse practitioner and oversees focused practices in urban street outreach and rural and remote communities in HIV prevention, hepatitis B and C, and mental health across the province of Ontario. In her free time, she volunteers as a primary care nurse practitioner to support persons who are at risk or are being trafficked. Mia is an assistant professor at York University and oversees the primary healthcare nurse practitioner program. Mia is also a director of implementation at the Viral Hepatitis Care Network. At present, her research focuses on increasing hepatitis B, C, and HIV screening and treatment through alternative diagnostic and system approach. She is especially interested in increasing screening uptake and linkage to care among prenatal, pediatric, gay, and bisexual men and women engaged in sex work who use drugs.
Good morning, everyone. It's always very nice to see you. Thank you so much for coming. Also, it's always very difficult to follow someone like Guillaume because that was such a good talk. Thanks so much to the organizers for inviting me. I've given a few different versions of this presentation over the last few years, and I'm really hoping to look at some new things. And I also just would be remiss if I didn't mention that just by coincidence, because an American speaker couldn't come, this entire clinical session is actually presented by nurses. I don't know if that's ever happened before, but I do want to give homage to, I believe her name was Gail Butt. I think her PhD was in 2009 around nurse-led models of care for Hep C, and I believe she was somehow associated with CAN Hep C way back in the day. So, leader in our field for sure. I also changed the title of my talk. I often do that. These are my disclosures, and then in terms of disclaimer, treatment in pregnancy is not Health Canada approved, and I will be speaking about treatment in pregnancy. And then I think another really important disclaimer is that language matters. So we are moving away from saying women or pregnant women, and this is coming from lots of different places and spaces to say pregnant people, pregnant individuals, pregnant patients, birthing people, and chest feeding folks. There's been a lot of work in this area, and using the term pregnant person does not discredit the experiences of cisgender women. In fact, it opens an umbrella for everyone to be included in obstetrical care. This is really important because a lot of the American guidelines that talk about care for trans folks that are pregnant, just going to show you these two underlined links. Look at that. This is now what's happening, south. They're taking away resources around this type of work. So just really important to acknowledge that. Okay. I'm going to jump in with some definitions of care. Sometimes people use the terms perinatal and prenatal interchangeably. They mean slightly different things. So perinatal care really talks about preconception, intrapartum, prenatal care, birthing, and then all the way into that infant stage. Prenatal care, antenatal care, is really from date of conception to birth. Does that make sense? So perinatal, prenatal, not quite the same thing. I'm mostly going to be talking about perinatal because we're really looking at that entire stage. Also important to note that midwives provide a tremendous amount of care in Canada. And they often serve folks who would be likely or at risk of having hepatitis C. So we really owe a lot of our obstetrical care, especially among folks who have difficulty seeking obstetrical care in traditional formats, to midwives. This is a bit old, but this is from a survey from 2009. The data was collected, and then there's been subsequent studies that have sort of shown at the state of prenatal care in Canada. And what you can see is even then, even before what we would call our primary care crisis, although I guess we've always been in a primary care crisis. Prenatal care has not been great. So there are many provinces that haven't had adequate prenatal care, and some of the ways that this has been looked at is who actually has a primary care provider, because primary care is the gateway to prenatal care. And those who are of reproductive age are the least likely to have primary care providers, right? Makes sense? They're healthy otherwise, and then they don't have a streamlined pathway. And a study's actually been done in Ontario to show that because of this, many people receive their first prenatal visit in an emergency room, right? So they're confirming the pregnancy, maybe they're getting the first set of blood work, or in a walk-in clinic. This is obviously not ideal, does not promote comprehensive, holistic, trauma and violence-informed care. There's been a really nice analysis of this, that only 68% of people have an optimally timed first trimester ultrasound. So that sort of shows what we're doing in Canada at that time. I thought I'd start by kind of grounding us in the now. So what have we been doing? So in terms of screening, we've been doing risk-based hepatitis C screening. We've been looking at prevalences in some universal screening studies and in some risk-based studies, and those differ, and they differ by province. We know that there are maternal complications when people have hepatitis C in pregnancy. We know that some of those end up being pediatric complications, like preterm birth as a major marker. We've shown, and we'll go through some of the work around postpartum treatment that's been done in the US, where it's been shown that postpartum treatment is poor. I'm sure everyone in this room knows, but breastfeeding and chest feeding is absolutely okay with hepatitis C, and it's really important that patients know that, because lots of people don't breastfeed because they think they can't. And then in terms of vertical transmission, we know that kiddos who acquire hepatitis C vertically have higher risk of advanced liver disease much younger in life, so we really need to work on linking those kiddos to care. There's some different studies around different rates of vertical transmission. We'll chat about that a little bit. And then some work done by Jen Fleming has shown that even when a person is diagnosed in pregnancy, the uptake of infant screening is only 29%. Okay, so what's new? So in the last 5 years, I would say, maybe 10 for number one, we've seen, and this has been done by the BC group, that rates are increasing among, and in the BC study, it was noted as women. So let's call that the reproductive group, those who are maybe in preconception stage, and of course they could also be in postpartum stage. And in that same study, it was shown that treatment uptake was low. I'm gonna share the guideline, but I'm happy to announce that officially, I know I've been saying this for 3 years, officially, we have a universal screening and pregnancy recommendation from our obstetrical society, which for all the practitioners and health systems and services researchers in the room, Canadian practitioners love guidelines, right? So we hope there'll be some good uptake. There is sufficient evidence by AASLD to recommend case-by-case decision-making for treatment in pregnancy. I'm going to chat a little bit about the movement towards screening differently in infancy, but as per the 2021 Canadian Pediatrics position statement, it was still recommending screening at 18 months. You all know children can be treated as young as 3, so screening, diagnosis, linkage to care for those 3 years is massively important. And okay, so I'm going to jump into this entire cascade, right? So we're going to start at that preconception stage. So we chatted about increasing rates, looking at structural and geographic barriers to that, and I think Guillaume's work will actually overlap with a lot of this in a really nice way, because we know that point of care testing programs actually allow this entry and gateway into care. We know there are not inclusive, well-studied models of care that have a gender focus, right? We've done a lot of work, and a lot of people in this room have done a lot of work around different groups that have intersectionality in terms of the things that happen in their lives, but the gender-based models are absolutely missing in the literature. This is not about preconception per se, but some work done at UHN by our group, done by Dr. Mendelowitz, actually showed that in this population, planned termination is higher than the general population, right? And so I think that's really telling and might actually alert us to think about, so planned termination is actually really difficult to access in Canada, especially early planned termination. And so perhaps there might be other folks that just actually didn't want to go through that pregnancy that had to. Chelsea Masterman has also looked at stigma in some different settings, and specifically some of the work that came out around pregnancy is that there needs to be a link back to HCV care and the identity of being maybe a mother or a caregiver or a person caring for others. And that's been the connection that has been so evident in the literature, because not having these connections and having that stigma and shame has led to, yes, people not having their own health-seeking behaviors, but also not attending appointments for their kiddos. Curtis Cooper has also done some really nice work that was qualitative, and I just want to highlight 2 pieces of information that came out of this study. 80% of people feared that they were going to transmit Hep C to their partners, and they were more likely to seek out a partner and have children after cure. Right? So this is really solid data that we need to focus on preconception treatment. Yes, we're going to talk about treatment in pregnancy, but the ideal scenario is treatment of partner, person, preconception. In terms of universal screening, so there's been some different studies in Canada. British Columbia has done a universal screening study which had a 0.4% prevalence. We've done some work that averaged out to about around 0.6%. We worked with Saskatchewan to look at their uptake and screening prevalence, and it was about 2%. And then when Alberta did their screening program, it was actually quite low at 0.1%, and that was done by Alexandra Thompson. And here it is. So we've got our SOGC recommendation just this week. I just want to point out, I think the guideline that was the original Hep C guideline pregnancy was like 97, and this is guideline 458. So you know, all these guidelines have happened in between, but it's just been a really long time since they updated the guideline. There's a lot more than just the screening piece. I think the screening piece is probably the most important. And just to highlight the language, because it differs by US group in terms of what they're recommending. So in Canada, it's going to be first trimester of every pregnancy. Super important, right? And then looking at if people are known to be antibody positive, of course, direct to RNA testing. Or if you're in Manitoba, using the Manitoba algorithm. Okay, so we've got the screening recommendation. That's wonderful. It's now implementation science time, because we know that even in a universal screening program, people are still potentially not linked to care. So we did some work at London Health Sciences Centre, and although it's very small numbers, many people did not get a Hep C RNA after antibody. We've kind of probably fixed that now because of reflex testing, but some people might still have had a past RNA, so they won't be reflexed. And then some people were not referred, even with a positive RNA. We did some informal interviews with the OB-GYNs who were doing this work, and many people, and I think it's common across specialties, is discharge back to primary care, right? OB isn't going to treat them in pregnancy, discharge back to primary care for follow-up, or even the confirming of HCV RNA. So just to review what's been happening in the US. So IDSA, ASLD came out with their recommendation in 2018. CDC picked it up in 2020. And the crucial thing, as we understand from our American colleagues, I think, John, correct me if I'm wrong, is that until the Obstetrical Society makes this recommendation, it's not going to get picked up. So that happened in 2023. What has happened since? So these are 2 different studies that looked at if there was going to be a blip in this testing uptake, and this was actually before the ACOG recommendation came out. So you can see it only went up to 2021, or in the second study, 2022, and they have increased, but they're still terrible. Right, like 40% after a universal screening recommendation. Just so you know, British Columbia, and again, British Columbia folks, correct me if I'm wrong, I think even before any kind of recommendation, it was already moving up to 50, 60%. So even without the recommendation, we were already kind of doing better than post an American recommendation. It will be interesting to see what happens when they look after the 2023 recommendation in the US. And then here locally, we've looked at a few different things, as well as Quebec has a really nice cascade of care that was presented at CLM in 2023. And so I just wanted to revisit this work to show that uptake is poor and there are some factors. We know that from the US, it's somewhere between 10 to 20% around postpartum treatment. These cascades are actually quite a bit longer than the US studies because they only looked at a certain time frame of follow-up. But still, postpartum treatment is poor. And then in Ontario, we've also looked at this, and Dr. Mendelowitz presented this at AASLD 2023. And I think one really interesting thing here is to show that people can be pregnant up to 5 times before treatment if they're ever treated. So we are missing opportunities. So what could we do in postpartum care if there's not good acceptance of prenatal treatment? This was a working group and a community of practice that was led by the coalition, actually, from the US. And to summarize, really what it came down to is co-localization of care with non-specialists, right? So the things that we're already doing in so much of our work is sort of what came out of this. And we're not restricted by the reimbursement issues that they have in the US, right? So they have different systems and different rules around who can be treated, and especially because people lose their insurance 6 weeks postpartum, lots of people are trying to get a prescription to folks at their discharge from labor and delivery. So just to sort of put that into context, I don't think many people who have just gone through labor and delivery are thinking about much, except how to keep another human alive. And I think it's a really big burden to be thinking about all of these things at once. So some rationale for treatment in pregnancy. Treatment likely reduces, if not eliminates, and we don't know, vertical transmission. Jen Fleming also showed this, that there is a bit of a cutoff in terms of viral load for transmission. So if we can get the viral load to 0, can that actually prevent transmission at labor and delivery? Women are not treated postpartum, and prenatal care may be the only opportunity where they're engaged in care. Women want to be treated. Our prenatal studies have shown some promise, and others have done some work as well. And then, what do people think? What do patients think? What do pregnant patients think? And at least in our work, folks who identified as women reported treatment in pregnancy to be tolerable and perhaps decrease shame and blame because they could actually do something about it. And we're running an observational study on that right now. So I'm going to focus a little bit on some of these studies. The first is around that acceptability piece. And Tatiana Kushner did a really nice study in the US. It's quite some time ago now. It was really even before Canada was using DAAs at the level we are. And 60% of people wanted treatment in pregnancy if it would reduce the chance of vertical transmission. 20% of people would take treatment in pregnancy even if it would not reduce the chance of vertical transmission. These studies have been replicated in other parts of the world, like Egypt, Ukraine, and Pakistan. And again, there's been pretty widespread acceptability. There's been a few observational studies to look at treatment in pregnancy. Again, one by Tatiana Kushner, which used soft lead and soft val, and then used Gleep-Pib postpartum. And you can see the cascade of care there, just to look at sort of who got what when, these insurance issues that really play a huge role in the US around access. And then another study in India where they also used soft lead, looked at primary endpoints of SVR, infant antibody and RNA status, and everyone achieved SVR, very small numbers, and there were no children born with hepatitis C. So one of the reasons why perhaps we've been waiting so long to do work around treatment in pregnancy, despite HIV treatment in pregnancy, despite hepatitis B treatment in pregnancy, is potentially because folks thought, well, there's nothing we can do about it, but also because of some thinking that there might be ethical concerns in terms of putting folks who are pregnant at risk in an unnecessary way around clinical trials. So I wanted to share this really nice statement with you from ACOG, and it does apply to kind of all of our work across all disciplines, that we should not be restricting people's consent to do clinical research in pregnancy. Does that make sense? Because it's informed written consent, it's absolutely their choice, and there really needs to be fair distribution in terms of that uptake, and we need to do more work in treatment in pregnancy. So this is a study called STORK. It looks at the safety, tolerability, and outcomes of soft val in chronic hepatitis C in pregnancy. I'm just sharing the data that's up to what was presented at AASLD 2024, where 50 people were enrolled and 34 had achieved SVR. I believe I can share that right now enrollment is up to 58 and the target is 100. So maybe a couple years off from finishing it, but it'll come. And I think it's just a very crucial study to show that, number one, it's international, there's many sites, lots of different priority populations, lots of different folks have been enrolled in this trial, and to show that SVR is likely going to be near perfect. And so far, no kiddos have had a positive HCV RNA. Hepatitis C screening in pregnancy is about more than Hep C, right? I think 2 years ago, Alex Wong from Saskatchewan gave a really nice talk in this session about syphilis, and I think we've all forgotten about it. So if you're doing hepatitis C care, you need to screen for syphilis, right? We can't just do Hep C. We're already doing B, we're already doing HIV. We need to screen for syphilis. In Alberta, in their universal screening program where they screened over 50,000 pregnant patients, they had 87 fall positive for hepatitis C, and 21% of those were co-infected with syphilis, right? So this really matters. Obviously, congenital syphilis is a massive deal in Canada. We need to make sure we're screening for multiple things at a time. And this is just a really nice note from, again, SOGC, speaking about how important this is. So I'm going to switch gears just for 5 minutes. 1 second. To chat a little bit about the infant side. And there's an abstract on this later, but just to sort of think about the full process. So we've got the universal screening and pregnancy guidelines from the different organizations, and now SOGC. And then there's been some shifts around changing infant screening. So I mentioned this position paper from Canadian Pediatrics, and again, practitioners love guidelines. So every time I talk to folks about this, they say, yeah, but Canadian Pediatrics says 18 months antibody screening. So the US has moved to some different approaches. ASLD, IDSA for a bit now has been recommending early infant HCV RNA testing at 2 to 6 months, and then the CDC has just recently sort of widely, there's been some nice follow-up publications on this, recommended screen at 2 months. If we screen and children are positive, we obviously need to link, and that's something that I think we're really struggling with in Canada, and I'm going to show a little bit of data on that. I'm going to give you a second to just read something that we published. So this is with permission. But when we think about screening at 2 months for HCV RNA, if it's negative, should we or should we not do an antibody? Right? So this is just one patient's perspective on why they wanted their child to be tested for HCV antibody. And it was highly related to the fact that they didn't want it to be a surprise that their child was antibody positive to them, right, when they were routinely screened, let's say in pregnancy, or let's say for STBBI screening when they are adolescent. So I think there's still flexibility, and we should still offer this antibody test at 18 months just to rule out that they're going to have a positive antibody for life. So we know based on Jens Fleming's work that infant screening is poor. We know that maternal antibody transfer goes up to 18 months, so this antibody test could happen at 18 months. HCV RNA testing could happen earlier. But what are we going to do to increase the uptake? There have actually been some small studies using OraSure antibody testing, which is not approved under the age of 15. But people have done it in research, and there's some, it's not a validation study in small models, but it did have good uptake. There's been some DBS studies that used both the remainder from genetic testing as well as some street outreach among younger folks in different parts of the world. Could we use a gene expert at the point of care? Could that be a model that works, maybe in settings like child services? And then how are we going to work in these types of reminder programs? So we know based on a US study that if children are screened at 2 months, the uptake is 91%. And at 18 months, it goes down to 60%, which is still better than what we've shown in Canada, but it's still not ideal. In Alberta, they actually called the provider to say, hey, don't forget to contact the patient to screen the baby, which is amazing. The microbiology lab actually called the provider to remind about infant testing, and that had a 52% timely uptake. Outreach to primary care and foster care has actually not been great in the US. Some studies have shown that up to 5 calls will occur, and still the infant is not screened up to 3 years of age. And then one thought we had, and we're trying to work on this, is can this be incorporated into the Rorkwell baby record? which is a national guidance document that most providers use in well baby checks because there's already reminders about hepatitis B. Should we put in a reminder about hep C? I do want to share the importance of pediatric treatment and some of the work that we've done. A group from Poland actually presented this at EASL 2024, and I think it's really alarming because this was in the DAA era. So average age of these children was 10 and a half, and they were all treated with DAAs, 135 children, and of them, still after 1 year, 7% had a significant fibrosis. So these are these vertical transmission cases, and we really need to focus on them. We've recently looked at IQVIA data for Ontario, and although this does not capture all children because children could be treated by non-pediatricians, these are the pediatric prescriptions that are happening in Ontario. So since 2017 to 2024, there's been 31 prescriptions. We think there's possibly 1,000 kiddos in Ontario who live with hep C that may not know their status, but even if 10% have been diagnosed, those numbers still don't match, right? Screening uptake and how many people are actually being treated. So I'm going to end just by talking about some remaining health systems and scientific questions, perhaps, and leave it with all you folks to sort of brainstorm how we might work on some of these. So how are we going to improve screening and treatment preconception? This is the ideal scenario. The US has recommended all adult screening. We don't know if we should do that here. We don't know that the data supports that. But could that be a way to increase this uptake? In some of our work using ICES administrative health data, it's most likely that people are infected prior to pregnancy because the average age of infection is around 30. In terms of prenatal screening, so we hope uptake will be good. We need to monitor it. There's been some work done in the US that, again, even after universal screening guidance, they did interviews with physicians, and people still didn't want to screen for lots of different reasons, and many reported only screening 30% of their OB practice. So there's probably some work to do there, but we can also maybe think about some easy things, like add the checkbox to the prenatal requisition, which we hope to do in Ontario. Treatment in pregnancy during breastfeeding and chest feeding. So thinking about, okay, maybe they missed the window for that early treatment in pregnancy, so there's a chance they're going to be on treatment in breastfeeding. Is that okay? Probably, right? That question is going to come up often. There's a tiny bit of PK data on it. Can we increase case-by-case decision-making with providers? So in one of our survey studies, this is actually really ironic to me, in one of our survey studies we ask, are you interested in treatment in pregnancy? And at that site, they must have had a conversation about how it's not Health Canada approved, because the exact answer was, my doctor said treatment in pregnancy is not approved. So, I mean, those conversations just need to happen in a little bit more of a flexible way, and outside of research, of course. And then in terms of infant screening and treatment, I think the workable baby record might be an option. We need to get some buy-in with the pediatricians, but pediatric screening is poor. Lots of people don't have primary care. Lots of infants don't have primary care. So we probably need to think about some different ways to do this. And then I guess of important note is people other than pediatricians can probably also treat pediatrics, right? So I know there's been some work done with some training in Ontario, and that's been a question that's come up. How do I treat kiddos? So these are non-specialists that are doing hep C treatment and treatment training, and they immediately want to know, how do I treat kiddos? Right, so I think there's interest, and we should work on supporting those folks. Okay, I'm not on time, but that's okay. I would just like to thank a few people. So lots of people have helped shape this work, including a lot of my patients, actually, in a very informal way. We also have a formal community advisory board. The work I presented today is from so many investigators, trainees, staff, and then there are two people in this room, Camelia Jordan. You've done so much to support me, and I'm so privileged to work with you.
That was an amazing presentation. I'm told we have time for one question, or maybe not. We have time for one question. Yes, please.
Question around, so 20% of people who are being seen by midwives, midwifery care ends 6 weeks after birth. So how can we end up wrapping in that screening at 2 months with that, quarter to a fifth of the population that no longer have that provider at a 6-week mark?
Thanks for that great question. And I should say, those numbers are flexible and broad, and it really depends on the province. Ontario and BC, very midwifery heavy. Not all provinces have that level of access. I don't know the exact answer to your question, but I will say having that 6 weeks of connection allows everyone to get their bearings and have time, right? So I know midwives work so diligently to try to make those connections to primary care. We still do see children fall through the cracks, right? Like folks in child services, they're often difficult to find. Sometimes also people disappear with their kiddos, and we can't find them. It's a great question. I don't know the answer.
I got some ideas.
We need more primary care providers. Maybe it'll happen, but I think it's a really important point.